elsewhere, and so are focused on making eliminating some of the hassle associated with signing up for health insurance, or making it more automatic in some way. And then there's a fourth component, which is often figuring out how to provide coverage to, or whether or how to provide coverage for people who are undocumented immigrants. Undocumented immigrants are generally not eligible for at least most of the public coverage programs that are available in the United States. So there's a sort of debate in this policy paradigm about, what should happen with that population. So that's one approach. A second approach that's commonly discussed, and this approach, so suppose you agreed with the people who are on the fill the gaps in the ACA camp that government intervention is okay, and we should be sharing costs broadly by health status, and that we should particularly be making sure that healthcare is affordable for low and moderate income people. But you're more negative on private insurers. You think they either don't create much value at all, or they actually do harm. And you think that the political system could bear much more substantial policy changes. That ends up, many people in that category support creating a single payer system. This is the type of thing that, for example, Senator Bernie Sanders supports. So going back to the sort of map we've been working with, what many people in this camp look at, they look at this map and say, this Rube Goldberg device is craziness. All these different programs are adding a lot of complexity. It's a hassle for individuals. It's a hassle for healthcare providers who need to figure out how to bill all these different forms of coverage. And we're not even managing to cover everyone. We've still got this 12% of the non-elderly population that doesn't have health insurance. Let's do basically what we do for people over age 65 and just create a single coverage program that covers everyone. That approach would indeed cover everyone. And in some ways, it would be a lot simpler than what we have today. That does come with some trade-offs. If you think private insurers do add value, then to the extent this single program doesn't have a role for private insurers, you're potentially losing that. Lots of people, current coverage would change. That transition could be substantively hard for people, but it's almost certainly going to be politically difficult. And because under this approach, a lot of healthcare that's now paid for in the private sector would instead be paid for by the government. So taxes would have to go up, and they'd have to go up quite a bit because we spend a lot on healthcare in this country. So that's approach number 2. And then there's approach number 3, which is, I think, people, if you sort of disagree with almost all of the premises of the first 2 approaches, you think that the government should have a smaller role in the healthcare system. You think people should basically be responsible for paying for the healthcare they use. So maybe people who are somewhat sicker should be expected to pay more for healthcare. And you think it's not an appropriate use of taxpayer dollars, to tax one person to pay for healthcare for somebody else. You're more skeptical about, how valuable health insurance coverage actually is, then you might end up in a place that says, rather than increasing the government role in the healthcare sector and spending additional public dollars to provide health coverage, we should actually be paring back existing publicly funded programs, and we should be trying to deregulate insurance markets where they are now. In practice, many of the sort of recent proposals in this vein have focused on rolling back some of the changes made in the ACA. So again, if we sort of look back at our coverage map, they do sort of 3 basic things. One of the big things is they would repeal the expansion of Medicaid eligibility that it was included in the Affordable Care Act. And they would also reduce federal funding for the Medicaid program as it existed before the ACA. They would eliminate or reduce the subsidies for people who purchase coverage on the individual market. And they would generally weaken the ACA regulations that bar discrimination based on pre-existing conditions and that require plans to cover certain types of care, on the theory that insurers could then offer plans that are sort of more tailored to people's needs. Many of these proposals also would then create, in the place of the ACA coverage programs, funding for states that they could, at least in principle, use to provide insurance coverage to some of the populations that were covered by the ACA programs. In general, all of the proposals in this vein that have been debated in recent years provide substantially less funding than the ACA coverage programs do. And so, the consequence of that is they place less burden on taxpayers than the ACA does. But it is also likely the case that these programs would end up covering substantially fewer people than the ACA does. So those are the three big coverage policy paradigms. So in the little time I have left before we move on to questions, I want to talk a little bit about healthcare spending and policy towards healthcare spending. So we spend about 18% of our economy on healthcare, which is trillions of dollars a year. So if we could find ways to spend less on healthcare without reducing the quality of care that we're receiving, that could be incredibly valuable. Our overall standard of living could be a lot higher than it is today, because those dollars that are currently going to healthcare could be going to other things that we think are valuable.
So Dr. Fiedler, when you're saying that we spend, do you mean like us as consumers, we pay, it's for co-pays, it's for insurance, it's for our medical bills, it's all that kind of stuff?
So it's not just what we as consumers pay, so it's our co-pays, but it's also what we pay in premiums. And in some case, maybe that's being paid by an employer. But $1 and my employer is paying to me for my health insurance is $1 they're not paying me in wages. So I'm ultimately paying for that. Likewise, a lot of healthcare in the United States is paid for by the federal or state governments, and that's ultimately being paid for by taxpayers. So what I'm talking about here is like all the different ways we pay for healthcare, whether it be individuals or employers or governments. How might we reduce the overall amount that we're spending? So to set the stage for how we might think about reducing healthcare spending, I think it's useful to understand what we actually spend money on. The first thing I'd like you to notice is that the two biggest bars here are hospital care and professional services. And professional services you can think of as physician office services, or there's also like dental care is in this category too, but mainly it's physician services. So 2/3 of what we're spending is on these two big healthcare service categories. And I highlight this because in debates over healthcare spending, there's often a lot of focus on what we spend on prescription drugs and what goes to administrative costs for health insurers and the profits of health insurers. But even if you take those two categories together, they're only about 1/5 of total spending. Now that's a lot of money because the pie here we're talking about is really large. And there are definitely places that we could save money in both of those areas. But if we really want to substantially reduce what we spend on healthcare, leaving out the sort of 80% that we spend on things that's not prescription drugs and not the sort of profits and administrative costs of health insurers, is missing a big part of the story. We really, I think, want to take a fairly broad view in where we think about trying to get savings. So if we wanted to spend less, and I promise this is the only equation I'm going to have tonight, but within each category, the amount we spend on hospital care is a function of how many hospital services we use, how many hospital stays do people have in a typical year, and how much do we pay for each hospital visit? How much does the hospital get paid by Medicare or a private insurance company or what have you for each hospital visit? So that number of hospital visits, healthcare wonks often talk about that as utilization, and that price per visit we talk about as unit prices. And it's the same thing for prescription drug spending. How many doses of each drug are we using? And then how much are we paying per dose? So ultimately, if you want to reduce healthcare spending, you're going to have to either reduce utilization or you're going to have to reduce the unit prices, what we pay for each service or item. So in the interest of time, I'm not going to do a sort of comprehensive survey of what our different policy levers are in each of these areas. But I think, most of the proposals that are out there fall in a sort of few broad categories. So on utilization, one commonly discussed approach is to reform how we pay healthcare providers to deliver care. Often in the United States, we pay a hospital for each visit or for each hospital stay, or we pay physicians for each office visit. And that does create incentives for healthcare providers to focus on increasing the volume of services they deliver, even if there might be more efficient ways to achieve the same health outcome. So there are a lot of proposals out there to try to change how we pay healthcare providers in a way that might eliminate some of those problematic incentives. Another set of proposals, these are particularly common on sort of among right of center policy experts, is to either increase or restructure how much of the healthcare bill we ask patients to pay for in the form of deductibles or cost sharing or co-insurance, with the theory being that if people were bearing more of the cost at the point they were receiving care, they might be more selective in what types of care they receive and maybe go without certain types of care that don't have high value. There's this sort of empirical research on that finds that when we ask people to pay more for their health care, they do use less care. My read of the evidence is, frankly, that often they cut back on things that are both things that are valuable and things that are less valuable. But there's a lot of debate about that question. On the unit prices side, I think there are three broad policy approaches that policymakers often discuss. One view is that we should seek to increase competition in healthcare markets. So, for example, with the theory being that if there's more hospitals in a particular geographic area that are competing for patients, they'll cut prices in order to attract more business, and so everyone will benefit from those lower prices. Another view is that for a variety of reasons, competition is not going to work very well in healthcare, and so that the government should play some role in regulating prices. It should set maximum price, should set upper limits, for example, on what can be charged for each type of service. And then a final related approach is that we should, that's sometimes discussed, is expanding public programs. One of the features of the US healthcare system is that public insurance programs, so that's Medicare and Medicaid, often pay much less to doctors and hospitals than private insurance companies do. And so there are a lot of proposals to give these public insurance programs a larger role. That could look like expanding the Medicaid program. It could look like creating what's called a public option, which is a sort of publicly operated insurance plan that people could purchase instead of a private health insurance plan. Or it could look like using a public program to replace all existing coverage arrangements, which is what we talked about with creating a single payer system. So just in closing, I want to circle back for these spending policy debates of where the disagreements are really coming from in these types of debates. Again, I think it's useful to break it down in terms of these sort of values questions and these empirical questions. One is just this sort of big question we were talking about before, is when is it legitimate for the government to intervene in the healthcare system? But another question that comes up here that comes up less in the coverage policy debates is how valuable are improvements in health? How much are we willing to pay for them? I think if someone came to us and said, you could spend $1,000 and add a year to somebody's life, I think we'd say, obviously, we should do that. So then the question is, well, what about if we could spend $100,000 to spend add a year to somebody's life? Should we do that? What about $1 million? What about $10 million? What about $100 million? Where you draw that line ends up impacting these questions of, well, should we actually cut back this spending? Or because it does have some effect on health, should we actually, even though we're spending a lot, it's actually worth spending all this money on healthcare? Then there are this set of empirical questions. I think first and foremost are just disagreements about how well markets work in healthcare. Are markets a good way to make sure that to ferret out less valuable care and create incentives to deliver care inefficiently? Or do they create opportunities for gaming, and do they tend to add complexity and overhead that just adds cost to the system? Another big question is, if we spent less, what would we lose? So for example, in the context of prescription drug policy, if we decided that drug prices were going to be lower, that would reduce the profits that drug companies made. And maybe they would invest less in research and development to develop new drugs. How much of that would happen? How many drugs would we lose? Would the drugs we lose be ones that really improve our health a lot, or would it be the ones that we really could do without? Those are the sort of, what does that trade-off actually look like, is one of the big questions here. And there's a similar set of issues if we were to try to reduce hospital prices, for example. And hospitals had to make do with less revenue than they have today. Would they cut back on things that reduce the quality of care that hospital is able to deliver? Or would they find ways to operate more efficiently so that we'd spend less, but get basically the same outcomes we get today? And then I think there's one other dimension here that's worth thinking about, which, as before, which is, I think politics are part of these disagreements too. There's a general pattern among policy researchers like me, I think, frankly, regardless of where they fall on the political spectrum, to be much more willing to consider policies that reduce healthcare spending than actual policymakers are. And there's a reason for that. The healthcare industry is very politically powerful. And when we're talking about things that reduce healthcare spending, those are things that reduce their revenue. So, and policymakers are responsive to that. Some of that, I think, is, the sort of nefarious things people think about of, campaign contributions and outright corruption. But I think that's not most of what's going on in most cases. In many cases, the local hospital is the largest employer in or one of the largest employers in many parts of the country. So if Congress is thinking about something that would reduce revenue for hospitals, the CEO of that hospital is going to come in to its member of Congress and say, listen, if you enact this policy and it reduces my revenue, I'm going to have to lay people off. And that's something that gets a member of Congress's attention. I'll say that I think some of the doom stories that the healthcare industry tells about what will happen if you reduce their revenue, they're not always true. But I do think that dynamic is a very real one, that every dollar less we spend on healthcare is a dollar less in income for someone else. And I think that often makes these disagreements very hard to resolve. So I think with that, that's sort of what I wanted to say in terms of setup, and I'm sort of looking forward to the conversation.
Great. Thank you so much, Dr. Fiedler. I think that was a great setup. I was wondering, could you actually go back to the table where you have the different, I really appreciate how you broke it down into values questions and empirical questions. So I'm going to kick off with a question and then I'll hand it over to Anna, because I think we've been getting quite a few number of really good questions in the chat here. So you said in the beginning that with empirical questions, we can do studies, like we can study that stuff. Yep. We can come up with answers. And then, do we have those studies? Can we just kind of wipe the question? Can we actually just wipe the questions of those off the table because they're kind of solved and answered through science? Yeah.
So I think on this question of does expanding coverage improve health, I think the answer is increasingly, well, we know a lot more about this than we used to. So one of the challenges with this question, for example, is we don't randomly assign health insurance to people generally. We don't generally say, you're going to go uninsured and we're going to give you health insurance. There would obviously
be how you do.
Big ethical problems with that. But the problem is, in practice, the people who have health insurance tend to be pretty different from the people who don't have health insurance. So it's often been very hard to figure out, okay, I see these people with and without health insurance have different health outcomes, but is that because one person has health insurance and another person doesn't? Or is it because the person without health insurance is also poor and there's a whole set of other things that are hard in their lives that are causing their health outcomes to be worse? We have, through a bunch of work over the last several years, I think we've started to get evidence that actually, yes, health insurance does improve the ability to access healthcare and does improve health. Often they've come through cases where so people, for example, have been looking at states that expanded their Medicaid programs under the ACA versus states that didn't expand their Medicaid programs under the ACA. And what they found is that programs that expanded their Medicaid programs in the populations affected saw that mortality rates went down. There was another, something I worked on actually at the tail end of my time in the Obama administration, where the IRS sent letters to people saying, you didn't have health insurance this year, and we know that because you pay the penalty under the ACA's individual mandate. There are these coverage options available to you. You may want to think about it. So they were then able to follow up and see that, well, some of the people who got the letter got health insurance, and some of the people, among the people who got the letter, mortality actually fell, suggesting that getting health insurance actually did improve people's health. And the key of this is, sorry, I should have said this, they actually did randomly decide who they sent the letters to, because they didn't actually have enough money to send letters to everyone. So they sent as many letters as they could with the money they had, and they randomly decided within that group who they could. So I think we have better evidence that coverage improves health. I think the latter two questions are actually, while they're in principle empirical questions, they're just a lot harder to answer, right? Like you sort of have to change the whole healthcare system to sort of exactly answer them. So we try to learn in bits and pieces from experiments here and there, but it's not easy. And I think part of the reason the disagreements persist is because, getting exactly the right evidence on these questions is often really hard.
Oh, great. So it sounds like case is not settled yet on the answers there. And so it might be other factors like intuition or personal experience, or maybe kind of what the party is saying that's leading people in believing one side or the other when it comes to those things.
I think that's right. And I don't want to say that there's no evidence on these questions. I have views on some of these questions that I like to feel are fairly evidence-based, but like part of the reason they are the topic of discussion is that the evidence base isn't perfect.
Great. Anna, let me hand it over to you.
Super. All right, so I'm going to stop sharing Dr. Fiedler's screen just so we can see everyone. So we'll start with the Q&As. Please send your questions into the chat. Keep them coming. Really cool to see them here. But first question is going to be from Kelly. So I'm going to find Kelly in our, let's see, trying to find Kelly. I haven't found her yet. So let me go to Stephen, actually. Stephen has the first question up, so I'm going to ask you to unmute, and you can go ahead and ask your question.
Hi, Dr. Fiedler. Thank you for talking to us tonight. I had a quick question. You had a slide that I believe showed that the U.S. spends 18% on healthcare as part of the GDP, and I wasn't sure if you knew that number roughly for Western European counterparts.
So it varies a lot. So the US is a huge outlier on what share of our economy we spend on healthcare. I don't know this exactly, but I think if you looked at Western European countries, I think that like top end is in the low teens. And there are countries like the UK that are in the single digits. And I think why this is a really big debate, and whether we're getting anything for that money is also a really big debate. So I think you're hitting on one of the questions researchers in this space wrestle with quite a bit.
Thanks for your question, Stephen. So I did find Kelly. So Kelly, I'm gonna unmute you and ask you to unmute yourself. So go ahead.
Awesome, thank you. Thanks for the presentation. That was very helpful. I wish I had seen that maybe like 15 years ago when I first entered the workforce, and people shoved papers in front of me and said, "Here, pick a health insurance." But learning along the way. I was actually surprised to hear you say that not all of the states adopted the ACA. I thought they had to, and maybe if not, which ones didn't adopt the ACA?
So as it was enacted, states actually did have to all expand their Medicaid programs under the Affordable Care Act. But this was the subject of a Supreme Court case in 2012. And the Supreme Court's decision was that the federal government couldn't make it mandatory for states. It had to be optional. And so as it's turned out, most states have adopted, but it's 12 or 13. It's changed a little bit recently. It may actually not be 13. It's in the low teens. States have not adopted the ACA's Medicaid expansion. Those states are generally in the South, with almost no exceptions. South and the Midwest, I guess. But the sort of largest states that are still holdouts are Florida, North Carolina, Georgia, and Texas. Are the big holdouts at the moment. And, I think that ultimately reflects that these are fairly conservative states that are, I think both have substantively different views on what the right healthcare policy is, but also I think are, because the Affordable Care Act is associated with Democrats and was passed by Democrats, hostile to the ACA in particular. The other parts of the ACA, the parts I was talking about that affect the individual health insurance market, those are in effect nationwide. There's no state option to opt out of those. And that's because they're fully financed by the federal government.
So Dr. Fiedler, just to state it again, so the part that the states can adopt is to expand the Medicaid part and who qualifies for that. So more people fall under that. And that's a state-run part of the healthcare system.
That's right. So they can move the income eligibility threshold up to 138% of the federal poverty level. So if you think about for a single person, that's a little under $20,000. For a family of four, that's about $35,000. Those numbers aren't quite right, but roughly. And so most states before, often kids were eligible, or parents of young children were often eligible at those income levels, but adults in those income ranges generally weren't.
All right, our next question up is Daniel. So Daniel, go ahead, unmute yourself.
Hi, Dr. Fiedler. Thanks for sharing all your knowledge with us. My question comes from, I listen to this podcast called An Arm and a Leg a lot. I don't know if you've heard of it, but I would recommend listen to it. And it talks a lot about, in the end, I don't think this is where the podcast is intended to go, but it ends up talking a lot about billing, like the billing departments of hospitals, and kind of a little bit about their incentives and how they work. Mm-hmm. And also a lot about like the effort of individuals trying to fight different bills coming in. And I saw your breakdown on the different costs, and I was kind of wondering where that might fit in. And I'm kind of asking the question for two different populations. Do you have an estimate of any sort on the magnitude of the cost that comes from the hospitals manning their billing departments, and also maybe an estimate on the lost hours that individuals have had to trying to fight different bills that they get? Thank you.
So, overall, the healthcare pie, hospital care writ large, my slides are stuck here, is about 35% of the slice. Of that 35%, how much is administrative overhead? I don't have a number off the top of my head. It's certainly a minority, but it's not a tiny amount of that. Most of what hospitals are spending money on is physicians and nurses, and then equipment and facilities and things like that. But there's they also employ a lot of people in their billing departments. And so it's not a trivial amount. And then the hassle costs for individuals are large too. I mean, and it's not only hassle costs, right? In some of these situations, so this has particularly been something people are discussing in terms of out-of-network care, that, someone will end up, they'll go to the hospital, they will, say for a hip replacement, and they've chosen a hospital that's in their network, they've chosen a surgeon who's in their network, but it turns out that the anesthesiologist who puts them under, who they played no role in choosing, is not in their insurance network, and that anesthesiologist has a very large bill. And so then people have to figure out, okay, like, where is this huge bill that my insurance is not covering coming from? why is it there? And then often, so that's a hassle, but it's often the bill's like quite large. It's like many hundreds of dollars, maybe more, thousands in some cases. And, so it's a direct financial burden too. So I think this is, when we were talking about this debate between, building on the current system to try to fill the gaps and, creating a single payer system, I think this is one of many of the things that, single payer advocates say is like, listen, you got all these crazy edge cases where people are like having to deal with the, craziness of the fact that we pay for healthcare through, in 8 different ways. And it creates burden for providers. It creates burdens for people. Like, why are we dealing with this?
Maybe actually now's an opportunity for you to expand a little bit on the single payer system. Can you tell us a little bit more about how it would work? And is it really just that there's this kind of one public policy that we would all be on and we'd all pay into? Can you just lay that out a little bit more for us?
So, I mean, it can work in a bunch of different ways. So you could have something that looks a lot like the current Medicare program, where historically, at least, everyone was on sort of one program that's actually directly operated by the federal government. That's actually
you're going to have to even explain like how that works now.
Yeah.
Like,
so if you're over age 65 and you meet certain criteria that most people over age 65 meet, you are automatically enrolled, generally automatically enrolled in Medicare. There are exceptions to that. Often automatically enrolled in Medicare is probably more accurate. And you do pay a premium for that coverage, and you have some cost sharing under your Medicare coverage, but most of the cost of your healthcare is then being borne by the federal government. And the federal government then, when you go into the hospital, it pays the hospital. When you go into the doctor's office, it pays the doctor. It also determines how much the hospital is going to be paid, how much the doctor's office is going to be paid, and so on and so forth. So a single payer system would potentially, expand that type of system to everyone. You could also sort of have cousins of a single payer system, which in fact is a little bit more like the Medicare program we have today, where you could be covered through that coverage program, but you could also take the money that the federal government would otherwise spend on your care and use it to buy a private insurance program. So in the Medicare program right now, there's a private insurance plan. There's a program called the Medicare Advantage program, and about 40% of people on Medicare actually are enrolled in Medicare through Medicare Advantage. So they actually get coverage through a private insurer that are often the same private insurers that offer coverage through an employer or in the individual market, even though they're covered under Medicare. And if you could create a sort of system like that, for the whole population as well.
And so we would be in that kind of Medicare for all or like single payer system. And we would pay for it through our taxes. So we'd all pay taxes. We're all paying taxes. Most of us are paying taxes to the government, right? And then everybody gets the benefit of the healthcare system from it. So it's not like I have to sign up or I get to choose whether or not I sign up, and I can shop around on the market, or I could refuse from my employer or whatever. It's everyone gets bought into it. That's how that works.
That's right. That's right. And you could have a hybrid, right? Again, in these systems where you've got, a public plan and then a private plan, it could be that by default you're in the public plan, but if you want to shop around and end up in the private plan, you could do that. And then these proposals often also vary. So, most systems that look like this internationally, actually people do still have some co-pays or co-insurance or something that they pay when they actually need care. Many of the proposals that have been talked about in the US context, particularly Senator Sanders' proposal, actually have basically no co-pays and co-insurance, the exception of prescription drugs. And so, that means that people are paying less when they access care, but it does mean that that tax burden is going to be higher to pay for that.
So I do want to give everyone a chance who has a question to ask. So we are approaching 8 o'clock, but after our breakout rooms, we have additional time for questions. So definitely stick around and you'll be able to ask Dr. Fiedler your question. So just a couple more before we go to the breakout rooms. We'll push it a little bit past 8 o'clock. So I'm going to unmute Carol Fisher, and go ahead. I know you had a couple questions, but if you want to just ask one of them, that'd be great.
Thank you. So Dr. Fiedler, thank you for your great presentation. My question is really asking you to explain a little bit more your third empirical question, which is assuming we're going to have a Republican Senate, assuming that we're going to be having a conservative Supreme Court, what can, in your mind, what can President Biden do through executive order to expand healthcare services to a greater portion of the US population and have it stick?
So I think there are, frankly, real limits that to what can be done through executive action. But I think there are a few examples of things that can be done through executive action. So one is, I talked a little bit about these subsidies that are available for people who buy coverage on the individual market. There's a complicated formula for how those are determined, but some of the parameters in that formula have to be updated over time as health costs and other things change. The Trump administration made a decision a couple of years ago in how they were going to update the parameters in that formula that had the effect of making the subsidies somewhat less valuable than they were before. So a Biden administration could think about reversing that formula change, making those subsidies more valuable, and hope that that would pull more people into the market. Another decision that the Trump administration made was to reduce what the federal government was spending on outreach and advertising to encourage people to sign up for coverage programs they might be eligible for. I think we do have some evidence that while the effects of that type of spending aren't huge, they do have some effect in getting people to come in and sign up for coverage. I think it's possible a Biden administration might change that. And then I think there are other things sort of in that vein that could have an effect. I think there are some other big changes that could happen on the Medicaid side. The Trump administration has implemented various changes in what they allow, what limits they allow states to place on Medicaid eligibility. The most sort of high-profile one is that generally the way Medicaid works is if you meet the income requirements, you're eligible. The Trump administration has allowed states to only allow people enroll in Medicaid if they're working. And so that has reduced where it's been implemented, and actually they were blocked by a court ruling, so they're not in effect right now. But where it's been implemented, that has resulted in reductions in coverage, partially because some of the people aren't working, and partly because in many cases, documenting that you're working is actually like a little bit challenging. And some of the systems that states have set up to through which people can submit their paperwork don't work very well or are hard to work with. And so you end up with people falling off the Medicaid program because of some of those paperwork hurdles. So those are a few examples.
All right, thanks for that question. So I know that there's a couple more questions to be asked, but we're gonna jump into the breakout rooms right now. And also, when you go in there, if you run out of questions, there's also a survey that I put in the chat. But here, these breakout questions is, what is one thing you learned? What's one question that you still have? And did anything change for you as far as your perspective on healthcare? So there's going to be 4 rooms, so there'll be about 4 to 5 people per room. We'll take 10 minutes. Don't be shy, turn your camera on, chat with each other. Most likely this is the only time you'll meet these people, unless you know them in real life. But you'll be randomly assigned to a breakout room and have some great conversations. Here we go. Okay. Well, I hope everyone had a just fruitful conversation. I'm gonna quickly turn over to Laura so she can do some just housekeeping logistical things.
Great.
And then we'll take it back to the questions. So go ahead, Laura.
Yeah, and if in the breakouts you surface some additional questions that you want Dr. Fiedler to answer, please put them in the chat for Anna. I'm just going to share my screen again really briefly and say, if you do have to peel off before we, is that showing up?
Yes.
Okay, great. If you do peel off beforehand, please, we would really appreciate if you would take our 1-minute survey. If you go to civicseries.org/survey, the link is also in the chat box. We read all of the feedback that we get about the events that we run, and we change our events based on the feedback that we get. So we really would love to hear from you. It's very invaluable to us. Want to also let you know that we have a civic media researcher named Adam Gismodi who compiles readings from across the political spectrum on healthcare. So we talked about today empirical evidence, we talked about values. If you want to hear from some of the people who are writing from different perspectives, then go to civicseries.org/news and you'll see the recommended readings for this session. Also want to share that we have a few other events that are coming up. One that's posted is on climate change. It's going to be in January. Where are we now? Where are we heading? We have an MIT professor who's going to join us and talk to us about climate change and answer all your questions. And then we're also working on an event on policing in the United States. So stay tuned for that. If you give us your email address, then you'll receive event announcements about these coming up, or stay tuned to our social and website. But let's go back to the questions. Anna, let me pass it back over to you.
For sure. I'm going to have Deborah Bohr. Deborah's been very patient. Her question has come up earlier. So Deborah, I'm going to ask you to unmute yourself and you can ask Dr. Fiedler your question. And Dr. Fiedler, your microphone is still muted.
Great.
Hi. I had a couple questions. Why have certain things like the shift to outpatient services, telemedicine, nurse practitioners, and so forth, we're getting away from inpatient hospital care, not lowered the cost of medical care?
So, I think part of what has happened, so let me take the sort of inpatient to outpatient shift. I think, one of the things that often happens when we make care more accessible is it may be lower cost to deliver each service, but we've made the care more accessible, and so people want more of it. And that may actually be good and appropriate, but it means that like telemedicine in particular is actually one where many of the trials with it, you might think you're going to save money this way and you don't end up saving money because people use more care. I think on the inpatient to outpatient transition, I think the other thing is it's not always the case that doing things on, an outpatient basis may be somewhat less expensive because you have the person in the hospital, or you don't have the person in the hospital at all. But, a lot of the cost associated with a procedure, say, is, the upfront cost of actually doing the procedure. And so, the cost may not be that lower, but on the other hand, if there's now a procedure that I can have and I can sleep in my own bed that night, I may be more willing to have it done than in a world where I was going to have to stay in the hospital for 3 days. So I think there are a lot of things like that. But I think the other thing is even where they do save money, we've got some underlying trends that are driving up costs. So there are just like a lot more things we know how to treat now than we did 2 or 3 decades ago. And so, we now deliver care for those things that we didn't used to deliver. And that costs money, and it sort of offsets savings we might have gotten from sort of other changes that were happening in the healthcare system at the same time.
Deborah, you want to go ahead and unmute yourself, sorry.
Oh, do you
Go ahead.
calculate at all the cost of defensive medicine? The fact that a lot of tests are ordered and a lot of things are, this plays into the overutilization because, fear of being sued.
So this is a sort of hotly debated question among health economists. I would say my reading of the literature is that the aggregate amount of defensive medicine in terms of its effect on spending is pretty small, that we're talking about probably something less than 1%. Part of that is because that, ordering additional, in absolute terms, the number of additional tests we may be ordering may be fairly large, but relative to like a whole hospital stay, it's just not that large. And a lot of what we're spending is, now there are people who think that this is a bigger deal in terms of the amount we're spending, and that the sort of research has been done has understated how much more we're spending on healthcare because of defensive medicine. But at least my read of the literature is it's probably not a huge deal. I actually think there are a whole set of other reasons not to like how we deal with sort of medical malpractice and medical malpractice insurance, in that, the sort of classic research on this is, lots of people who actually are injured as a result of medical negligence don't end up getting any compensation. They never sue. They never get any compensation. But then while most of the claims where there is a lawsuit and they win and they get an award, when people go back and look, they sort of conclude, yes, these were probably claims that deserved an award. It's a really, like, the legal system is a really high administrative cost way of delivering compensation when people are harmed. So I think there are lots of ways we might want to change our medical malpractice system, but I'm not sure how much it would reduce spending in the aggregate.
Thanks for your questions, Deborah. Jennifer, you had a couple questions as well, so I will go ahead and mute you.
Sure. Hi, Dr. Fiedler. I really enjoyed your talk. I'm a policy researcher myself, and I'm going to use that framing of empirical versus values question. So I'll steal that one. My question is about kind of this framing of the ACA as having three legs, a three-legged stool, and that one of the legs of the stool that's important for it to function is the individual mandate, which has been repealed under the Trump tax cuts. And I'm wondering if we have any empirical evidence yet of how the repeal of the individual mandate has impacted the ACA.
And quickly, for those who might not be available, Dr. Fiedler, if you wouldn't mind just quickly defining what the individual mandate means.
Yeah. So the individual mandate was a requirement in the ACA that people either have health insurance or they had to pay financial penalty when they filed their taxes. So when it was fully phased in, that penalty was the greater of $695 or 2.5% of people's household income. And then there were exemptions for people who couldn't afford, met certain criteria that said they couldn't afford coverage, and various other rules as well. So we don't have great evidence on what the effect of the repeal has actually been, because this is one of these, we don't have a control group. So like whole country, the mandate went away. There's a lot of other stuff going on at the same time. And so we don't exactly know what's been going, what the effect on insurance coverage has been. We know that over the last few years, the uninsured rate has risen somewhat. And we know that there are actually a few other reasons we might have expected the uninsured rate to be falling during that time. For example, at least until earlier this year, the labor market had been improving, and generally that's associated, when the labor market improves, more people have health insurance. So that might suggest that maybe there was some effect on insurance coverage of repealing the individual mandate. But on the other hand, there were other things going on at the same time, right? The Trump administration was changing policy toward the Medicaid program, and there's some evidence that that's made it harder for some types of people to get onto the Medicaid program. So teasing apart exactly what's what is hard. I've done a little bit of research looking at the implementation of the ACA that suggests that it did contribute to the expansion in coverage under the ACA. And the approach there was just, there was a very sharp drop in the uninsured rate among people with incomes too high to qualify for the ACA's various subsidy programs. And so that's suggestive, at least, that there was some effect of the individual mandate, but this is a place where we really don't have great evidence.
Thanks for your questions, Jennifer. I have a question just about an international comparison. So how does the, I guess, US healthcare system, and this is very broad, compare to different countries? Are there countries that, more countries that are similar to the US healthcare system, or are they all just vastly different?
The US is pretty unusual and I think along the way we are most unusual is in having this sort of patchwork system. Most other countries have at least a sort of coherent coverage program that if it doesn't cover everyone, most other developed countries have a sort of one program that sort of covers everyone. Now they may have like multiple private insurers that offer coverage through that program, but they're all part of a sort of single coherent program. And there are exceptions to that, and there are edge cases in other countries too. But like the structure where we've got a different system for people under 65, and then like, 3 different ways you can be covered, or Medicare for people over 65, and then 3 different ways you can be covered if you're under 65 is pretty unusual. The other way we're unusual is that we spend a lot more. So the question then is like, are we getting something for that? Or could we spend something more like, what most European countries spend and get outcomes sort of like what we get right now?
And just a follow up, in developing countries, is it usual or unusual for them to have a healthcare system?
I just don't work very much on developing countries,
Sure.
and I don't have a great sense of the landscape there.
Gotcha. So we have one last question. It's going to be from Laura, and then she'll close this out.
I'm lucky I get to ask the final question. So we covered a lot today, and one thing that I learned in Civic Series events and all of the dozens and dozens that I've attended is one thing that I get a lot of clarity on is how complicated the issue is. And I think that's something that I've gotten clarity on in this event is how complicated healthcare policy is. And if I thought it was complicated going into this, now I know it's even more complicated than that. But there's something that I heard a lot during the elections, and especially when the Supreme Court nominations were happening, and then the ACA is in the Supreme Court now. And, I heard a lot, well, if the ACA is repealed, then, millions and millions of people will lose health insurance. And I'm reflecting on what you shared about the empirical evidence side, that this evidence kind of suggests that health insurance leads to better health outcomes, but it's not like completely sealed. The envelope isn't completely sealed on that. So I guess, and clearly, if the people who want to have health insurance but can't afford it, that's a different story than people who just choose not to have it. So I guess, one thing that I'm left with here is it that people who are more right-leaning, who are more conservative, they're not concerned about healthcare coverage, whereas people who are more left-leaning, they really want to make sure that everybody has access to coverage? Is that a good way to think about how they see the problem differently?
I think that's right. I mean, I think left of center, politicians and policy experts tend to be very focused on expanding coverage. Now, I think there are people right of center who share the goal of expanded coverage or maybe even universal coverage, but have somewhat different views on how they want to achieve that goal. In terms of the actual policy proposals that right of center policymakers have put forward, though, they've generally taken the view that the government is too involved in providing insurance coverage, and we'd rather have the government spend less, even if that means that fewer people will be covered.
Well, it's a little bit after 8:30 East Coast time. I want to thank everybody who joined us for participating in the Civic Series event. Just a quick, for the people that I can see, breakout groups, good, really good, just okay. People like them. We should keep doing them. Okay, good. I'm getting some nods and thumbs up, and even some claps. That's nice. So thank you. And Dr. Fiedler, thank you so much for joining us. Really appreciate you
Thanks for
taking
having me.
time. You're a parent of a young child and you joined us for a Wednesday evening during your child's bedtime. So really appreciate your commitment to helping people understand this really complicated topic. So thank you very much.
Thanks for having me.
All right, good night, everybody. Please fill out our survey and join us for our future events. Take care, stay safe.